And now I will go ahead and admit everyone in. Hello, everyone. I think everyone's getting their audio set up. Hopefully people can hear me now. I'm trying to take a look to make sure we're all getting set up. I think so. Hello, good afternoon. Welcome to Track 5, Breakout Session 4 for the Health Equity and Social Justice Conference. I'm sure as you've heard a couple times, this is our 13th conference, but it is our first virtual, so we definitely appreciate any of your patience as we figure out some of the technical elements to this. So thank you so much. My name is Emily Tamblin. I am the manager for community partnerships with DePaul's MPH program. So thank you so much for being here. Thank you for spending your afternoon with us. We have some really fantastic oral presentations today. So this is oral presentations on health outcomes in diverse populations in Chicago. Our first up is going to be effects of the current healthcare system to accessing Pap smears for Black women in Chicago. That's going to be with Magdelene Thebaud, MSW candidate at the University of Illinois at Urbana-Champaign. Rebekah Monroe, a BA candidate, the research assistant for University of Illinois, Chicago, and Mariama Bounds, a BSN candidate with St. Xavier University. Next up is going to be understanding the effects of domestic violence on sleep with Daniel Schober and Susana Shrestha. With Dr. Daniel Schober, our assistant professor at DePaul University, Susana Shrestha, MPH with DePaul University. And then finally, we're going to finish up with the presentation on adapting evidence-based programming for community implementation with Padraic Stanley, program coordinator with Rush University Medical Center. We're going to go through all of the presentations back to back, and then we'll have time at the end for questions. Don't let that stop you from putting your questions in the chat. I'm going to be collecting those, and I will have those set up for the presenters at the end. So just pop those questions in as you go. We have your microphones on mute right now. If you would keep them on mute for the time being, towards the end when we ask questions, the presenters might ask you to take your microphone off or to take your mute off, but for the time being, if you could just leave it on. Let me know if you have any questions, and thank you so much. And we'll kick off with the first group. Thank you.
All right, thanks so much, Emily. I'm going to share my screen for the group one. All right, can everyone see the first slide? Wonderful. All right, let me just get set up. All right, so I'm ready to go whenever you are, Mags, Mariama.
Yep. All right. Hello, good afternoon, everyone. Thank you for being here today. So our research project is on the effects of the current healthcare system to accessing Pap smears for Black homeless women in Chicago. I'm Magdelene Thebaud.
I am Mariama Bounds.
And I'm Rebekah Monroe. Oops.
Okay, so the purpose of this study is to increase the health equity of homeless women in Chicago using a cultural capital approach rather than a view of deficiency within our clinical model, using an anti-racist, intersectional, participant-shaped approach that acknowledges the effects of systemic harm. We propose our study as a potential microcosm for what could be our healthcare system, which could benefit the homeless women in Chicago by implementing already existing interventions that address cancer health disparities regarding women of color.
For our research, we created 2 questions. The first question is, how can community outreach be better utilized in supporting cancer intervention implementations for homeless women of color in Chicago? The second question we have, what policy development practices are needed to include homeless populations in future healthcare insurance to create cultural capital and ameliorate health disparities? For our presentation, we have 3 learning objectives. The first objective is that by the end of this presentation, audience participants will have a better understanding of how to engage in community research regarding health equity that is more inclusive and aiming towards policy reform. Our second objective is that participants will learn of the barriers that women of color are experiencing homelessness face in terms of accessing primary care and other preventative measures that maintain health inequity. And then our last objective is that the participants within this presentation will be able to identify methods of preventative healthcare that are anti-racist, intersectional, and proactive, inclusive, and cost reductive.
Here we are looking at figures that show Black homeless females in Chicago, of which 46% are sheltered and 17% are unsheltered. Note that data found only looked at the female-male binary of sex, which is not to be confused with gender identity. The other graph shows that the overwhelming majority of the homeless population in Chicago are Black individuals, with 81% being sheltered and 76% being unsheltered. Another statistic by the Chicago Coalition for the Homeless showed that 58% of females were on the streets and 19% of females were in shelters, were formerly incarcerated. Two of the most marginalized populations whom the current system forces into such dismal conditions.
There are many barriers that homeless women of color experience when receiving pap smears and healthcare overall. To start, I would like to introduce the concept of social determinants of health and some of the categories that align with this. For example, a person's lifestyle plays a big role as a social determinant of health. Some other contributions to a person's lifestyle are exercise, eating habits, social life, socioeconomic status, and the community that you live in, because there are some communities who have more resources than others. Obviously, this means even more of a challenge for individuals who are experiencing homelessness.
The Combahee River Collective, a path-breaking group of radical Black feminists, was one of the most important organizations to develop out of the anti-racist and women's liberation movements of the 1960s and 70s. They famously wrote, "If Black women were free, it would mean that everyone else would have to be free." We thought this quote sharply brings to light the idea of a person's unique circumstances as described by Mariama with the social determinants of health. This will connect to our next few concepts, which I'll go over in the next few slides. What is intersectionality and why is it important to healthcare? Intersectionality theory, coined by Kimberly Crenshaw, is the concept of having several socially perceived identities, which can contribute to varying levels of oppression and privileges that a person might experience. For example, I identify as a white, queer, middle-class, atheist woman, and this may allow for different privileges and oppressions within society and different institutions and how different individuals might interact with me. For the next section, I actually will invite people to participate in the chat. Let me see. So the question is, what are the isms? And if you just want to take a few seconds or a few minutes, not a few minutes, but like 10 seconds and anything that comes to mind, like if you've heard of that phrase isms. And I'll just give a couple of seconds for that. So I don't know if I'm not saying it right, but I'll just go ahead and give a few examples. So for next slide. So when we say isms, we mean different forms of discrimination. So a lot of people know that as racism, genderism, also known as sexism, classism, heteronormativism, ableism, essentially different forms of discrimination based on different identities that people might be identifying as or be perceived as holding. Sorry, give me 1 second. All right, so these 6 are just a few as mentioned, and all of these can be huge barriers to accessing healthcare, particularly if you identify as having experienced multiple of these because of, again, how you might be perceived by others. The next concept I'd like to discuss is structural discrimination. This is a form of institutional discrimination against individuals of a given protected characteristic, such as aforementioned race, gender, as well as others, which can have the effect of restricting their opportunities. It may be either intentional or unintentional, and it may involve either public or private institutional policies. Anti-Black racism in particular is seen by many scholars as the catalyst for systemic discrimination. Like any institution, this can have a serious impact on how a person is treated, and particularly for this circumstance within our healthcare system. The community cultural wealth is the model we used for our particular proposal. We're using the community cultural wealth framework, which is embedded within critical race theory, and this incorporates an approach where a person is not seen as a victim, but an expert in their own survival, using social and navigational capital in particular. These are skills in maneuvering through social institutions which were not intended for communities of color to be able to navigate. And social capital specifically refers to the ability to navigate these networks of people and community resources, again, even though it was not intended for people of color. One such model is the community-based participatory research approach. This is a collaborative approach utilizing community engagement and partnership to identify and reduce disparities for underserved communities. This consists of 4 tenets, including community, trust, communication, and impact. A good example of this is showcased by Contra Costa Public Health. They utilize a holistic model that is shown to be cost reductive and proactive, addressing unmet social needs to make sure that the person as a whole is cared for. This helped inform our community outreach phase. Finally, for the concept aspect of this section, I'd like to talk about stigmatization. This is one of the biggest barriers to receiving healthcare and being in a stable environment, particularly for people experiencing homelessness. Women could and did tick off the options for housing on their fingers. You had to be crazy, addicted, or have a job. This was a quote from a study on homeless women experiencing psychosis in the US who said no to offers of help. This quote points out the crucial need for a holistic approach as opposed to the current fragmented approach that makes up the majority of the US healthcare system. An example of a more inclusive approach is exemplified by Pathways to Housing in New York. This is a housing first, client-driven approach, which believes in providing stability first that allowed for clients to be housed for longer stretches of time rather than risk potentially stigmatizing homeless individuals by implementing rules decided by those privileged with stable housing. This also led to higher satisfaction with services and more engagement with treatment. There was also no more cost than the traditional treatment approach. This study emphasized that to treat clients most effectively requires not merely medical and diagnostic skill, but sophisticated cultural understanding and the willingness to put one side our own cultural sensibilities about how we offer to put to one side about how we offer help and signaling our own goodwill to those who need it. This might be different for different populations, for different cultures. This idea explains why the educational component of our model is so important, which Magdelene will go over.
All right, so a little bit on the literature that gave us the methodological framework. There was a study done on homelessness and healthcare, which took place in Toronto in 2013. And researchers funded a hospital-like setting for a homeless population of about 1,200 individuals. The findings were then compared to the general population. It was then concluded that the homeless population has a greater need of health services than the general population. There was also a great amount of homeless individuals using the emergency department due to the lack of primary care. The researchers looked into ways in which Medicaid can expand, and alongside housing and behavioral health treatments, the homeless populations were able to visit the emergency departments less frequently. And so recidivism levels were lower, and this is the rate in which people return back into the criminal justice system. And that's due to the lack of resources in civilian life, such as no jobs, no housing, and healthcare needs not being met. And so more access to behavioral health and overall health means less people being admitted to outpatient services and the criminal justice system. And so here's some of the measured outcomes we are hoping to find. An increased trust between the participants and clinicians, an overall better health outcomes of participants, positive retention rate within the program, And so that in our secondary outcomes, hopefully the preliminary data will provide a reason for more funding for a larger and longer study.
Our multi-phasal intervention is made up of 3 components. First, a 30-day clinical trial that would involve an educational training for healthcare staff, organization collaboration, secondly, with community providers, largely around the Chicago area to help implement this holistic approach. And third, policy reform starting at the local level up to the national. We suggest our proposal would lessen the current health inequity that is experienced by those most marginalized.
So for the first phase of our plan, in order to be eligible for our proposed intervention, participants must show proofs of insecure housing, which could be, for example, a confirmation by a staff member from a shelter where they currently stay in. Also, they would also need to provide consent to participate in a pre, during, and post-study interview. And in regards to recruitment, we would like to go to shelters and organizations that serve homeless populations to tell them about this opportunity. And finally, in the first phase, we propose to collaborate with Rush University for educational training aimed at destigmatizing homelessness. We would do this by utilizing the cultural capital approach, as previously mentioned, as well as self-advocacy training to help homeless women access resources available to them. Our hope is that this could become a standard training used across the US healthcare systems. And on to our second phase of our methodology, we would like to reach out to local Chicago organizations such as Rush University Hospital, Chicago Coalition for the Homelessness, Gilda's Club, Above and Beyond Recovery Center, SHE, which is abbreviated for Sexual Health Empowerment, but is not local to Chicago, but a collaborative partner we would like to get in contact with. Also, we would like to connect with Community Connect. Our overall strategy is to partner with homeless shelters and programs to interview homeless women and the populations to better understand their individual health and needs, as well as some form of funding for future clinical trials and research.
Okay, and so for our third phase, we're hoping for some policy reform to be made, and hopefully we'll be able to talk to some leaders to be able to get an extended 6-month version of this trial. And so we'll want to start with some education campaigns in which we'll reach out to universities and high schools to address homelessness, city collaborations, economical benefits, wisdom from survival, and also share stories from the participants about those who experience homelessness. And then we'll engage with our city leaders, such as our aldermen and hospital administrations, and educate them on the data that was collected from the 30-day trial and the benefits. And so hopefully this will be the start of our probable expansion of our study. And then we'll talk to our state leaders, which include the Senate, state representatives, and then maybe make this a state policy, and so that rural and urban neighborhoods can have better health equity, considering the fact that in rural areas, there are not many options for healthcare to begin with. And this is important because homelessness is not exclusive to city areas. And then we'll want to hopefully see how this can go nationally, in which federal laws regarding universal health care is made for everyone in the United States.
According to the film What Counts, in the first year of the Care Connect pilot program in Contra Costa Public Health, the cost of caring for the 11 patients in the study was reduced by 2/3. If our healthcare systems connected patients to programs addressing unmet social needs, it would produce up to $72 billion in annual savings within a decade. This is a quote from the film What Counts, and we propose that our trial could produce similar results.
All right, and so for the main takeaways, using an intersectional anti-racist approach to research can help rebuild trust in healthcare institutions, thus increasing retention, reducing stigmatization, and decreasing negative health outcomes. This is especially important when working with populations such as homeless Black women who have so often been traumatized by these very types of institutions. There will be less expense for the hospital for them not having to cover a lot of the big surgeries that would be otherwise preventable due to primary care access. The economic impact on society would be that we wouldn't be burdened to cover the high rates of emergency department visits of the uninsured homeless individuals. Furthermore, hospitalizations and emergency department visits account for approximately half of medical expenditures for uninsured homeless individuals. Studies in the past have shown that long-term behavioral care saved the government $5,000 to $10,000 per person for chemical dependencies that are untreated in homeless populations. Lastly, the economic burden for the average cost per lifetime for HPV screenings is around $2,000 per person, and that would no longer be a burden for anyone that is at risk for cervical cancer.
Some limitations that we encountered and might encounter during our proposed intervention consist of no sample size for the population, as this was only a proposal, no statistical or qualitative analyses, and no current funding.
The current future suggestions that we would include would to meet all Chicago homeless shelters working with all sex and gender populations to obtain a bigger size sample, to apply for further funding, to collaborate with grassroots community organizations, such as prison abolitionists who may have a vested interest with a population overlapping with the homeless people within Chicago. Also to involve more people that experience homelessness into this model and future modifications in its development.
And so I'd like to end our presentation with this one quote. During a 1964 speech in Harlem, New York, famed civil rights activist Fannie Lou Hamer told the audience that she was sick and tired of being sick and tired. Although Hamer's words are often understood as a concise expression of Black folks' general weariness and anger at living under white supremacy and anti-Black racism, her attention to literal sickness, bodily vulnerabilities, and health outcomes for Black people are overlooked. And so we would like to honor this sentiment and actively pursue health equity in our future research. We would like to express our sincere gratitude to the entire CHEC team, UIC, Northwestern, NEIU, and especially the CHEC Senior Fellows, Maggie Nava and Dr. Melissa Simon. Dr. Juan Martinez, Dr. Breck Stockdill, Cassandra Osei, and Joy Wycliffe for amazing feedback, and then Gilda's Club for the insight and idea that sparked our project proposal. This is our references slide. And then we'll save the questions for later at the end. Thank you, everyone.
Thank you so much, Magdelene, Rebekah, Mariama. That was really fantastic. And I'm sure there are some pressing questions. So please, I would encourage the audience, if you do have questions, thoughts, there was quite a bit in there to unpack, to talk about. So please include those in the chat, and that's something that we will continue to follow up with. We're going to move on to our next presentation for the time being. So I'd like to welcome Dr. Daniel Schober and Susana Shrestha to go ahead and share your presentation.
Thank you, Emily. I'm going to go ahead and share my screen. Can everyone see the screen? Okay.
Great. Well, today's presentation is understanding the effects of domestic violence on sleep. We're excited. It's a new area for us. We have not looked too much into sleep yet, but we see it as an important health behavior that really drives some of the health disparities that we're seeing in Chicago. So looking forward to your questions and your feedback and things like that. So I will pass it over to Susana, and she'll walk us through the background.
Thank you, Dan, for the overview of our study. So first of all, I'm going to start with an important issue, which is a geographical-based health disparities that is prevalent in Chicago. So in the city, prevalent neighborhood-based health inequities create substantial disparities in morbidity and mortality outcomes. For example, life expectancy in East Garfield Park, which is a predominantly Black neighborhood, is 72 years, while life expectancy in the Loop, which is a predominantly white neighborhood, is 85 years. So this means that there's 13 years difference in life expectancy within a 10-mile radius. So these kind of place-based health disparities in Chicago needs to be addressed. Sleep, as we know, is an important health behavior. and it has a vital role to play in regulations of body processes and for our health and well-being. So the National Sleep Foundation recommends 7 to 9 hours of sleep for adults aged 18 years and older. In 2014, short sleep duration, which was less than 7 hours, was prevalent among 35.2% of all adults in the US. Sleep plays an important role in metabolic regulation, emotion regulation, memory consolidation, performance, and learning. And poor or insufficient sleep has been linked to various chronic diseases and conditions such as obesity, where there has been reported epidemiological link between short sleep duration and being obese. Insufficient sleep is also linked to various cardiovascular diseases, and conditions such as sleep apnea might predict various cardiovascular diseases like hypertension, coronary heart diseases, and stroke. Insufficient sleep has also been linked to causing diabetes, as sleep is linked to regulation of hemoglobin A1C, which is an important marker of blood sugar level. So domestic violence is a pressing public health issue, and public health efforts to reduce the transmission of COVID-19, such as stay-at-home order, isolation, and minimized social contact may be contributing to increased risk of domestic violence, and most specifically to children and women. Communities of color that face challenges with housing, employment, and economic stability may be at risk for intimate partner violence during the pandemic. Although interpreting changes in calls to domestic violence hotlines is nuanced, many cities are experiencing increases in calls, suggesting increases to domestic violence during COVID-19 pandemic. So the purpose of our study was to explore the association between being exposed to domestic violence and sleep. A recent study reviewed by Gallegos and colleagues examined the relationship between exposure to intimate partner violence and sleep across 22 studies, and they found a strong association across all the studies between being exposed to intimate partner violence and sleep. We also examined the relationship between exposure to domestic violence and sleep among 6 racial and ethnic groups in 9 different Chicago communities. And further, we also want to examine domestic violence exposure and sleep outcomes based on race and ethnicity, which is a limitation that Gallegos cited in their review. So moving on to the methods of our study. So the study is cross-sectional in nature, and we've used Sinai Community Health Survey 2.0 data. The data was collected from a community-based setting, and interviews and surveys were collected from people's homes. The data was collected from March 2015 till September 2016. The sample size was 1,543 adults. It was a multi-stage sampling, and participants were sampled from housing unit census tracts. The participants were English or Spanish-speaking adults, 18 years or older, residing in one of these 9 Chicago communities, namely Norwood Park, Hermosa, Humboldt Park, North Lawndale, South Lawndale, Lower West Side, Gage Park, Chicago Lawn, and West Englewood. So the variables that we used for our study was for dependent variable or outcome variable, it was sleep duration. And the question that was asked was, on average, how many hours of sleep do you get in a 24-hour period? And the responses were between 0 to 24 hours. This variable was converted to a dichotomous variable, and 7 or more hours of sleep was coded as 1, and 6 or less reported hours of sleep was coded as 0. The focal independent variable used was witnessed domestic violence, and the question for this variable was, have you ever witnessed domestic violence, or have you never witnessed domestic violence? And the responses were witnessed or not witnessed. The other independent variables or the covariates were felt stressed. So the question was, during the past 12 months, have you frequently felt stressed? And the responses were either yes or no. The other variables were self-rated general health status. So there were 5 categories: excellent, very good, good, fair, and poor. So the other 3 variables were household income, gender, and race and ethnicity, which had 6 categories. For the statistical analysis, we used binary logistic regression, a multivariate binary logistic regression, and the results have been interpreted with odds ratio and 95% confidence intervals. The logistic modeling began with unadjusted model first, and with covariates being added subsequently in the following models. The reference group for the fully adjusted model is an individual who has never witnessed domestic violence, has not frequently felt stressed, has excellent health, general health, has an income of 75,000 or more annually, and is a white male. All models were weighted and linearized. This statistical analysis was conducted using Stata 16. So I'm going to pass it on to Dan.
Thank you, Susana. So just to kind of start and to walk through the descriptive statistics and demographics, we looked at who had witnessed domestic violence. We found that a slight minority had never witnessed any domestic violence, about 45.7% of our sample. In terms of the frequently feeling stress in the past months, we saw a slight majority reported that they did in fact frequently feel stress, 54.4%. Looking at health status, we saw that the majority, about 67% of the sample, self-provided a health rating of either excellent, very good, or good, while about 32%, almost 33%, felt their health was either fair or poor. In terms of demographics, it's important to say, just for context, that in Chicago, if we're talking about annual household income, the median annual household income in Chicago is about a little over 57,000. And so what we see is that the majority of our sample, almost 80%, were below that median household income in Chicago, and roughly 20% were above that. In terms of sex, we had a slight overrepresentation of females at 56.5%. And then in terms of the race ethnicity of our sample, we had roughly 49% of the sample was Hispanic or Latino, with about 9.8% of the participants being Puerto Rican, 33.9% being Mexican, and 5.4% being another Hispanic or Latinx ethnicity. We had roughly almost 35% Black participants and 14.2% white participants. Then 1.8% were Hispanic of some other, a non-Hispanic of some other race or ethnic group. We can go to the next slide here. So this slide presents the results of our multivariate binary logistic regression. And what it does is examines the predictors of meeting sleep recommendations, as Susana mentioned. Model 1 on the far left is our unadjusted model. And what it indicates is that witnessing domestic violence is associated with a decreased likelihood of meeting 7 or more hours of sleep in a typical 24-hour period. Now, feeling stress in the past 12 months is also associated with a decreased likelihood of meeting sleep recommendations. You can see that there. So these are odds ratios that are being presented. Being below 1, that means that they're less likely to meet the recommendations for sleep. We also looked at a variety of different demographic indicators. If you look down the column in Model 1, you see things like general health, annual household income, sex, and race and ethnicity. And these indicators weren't significant predictors in the unadjusted model. So being female wasn't associated with decreased likelihood of sleep, nor was income, nor was race. Then if you look to the right, models 2 through 4 examine the robustness of witnessing domestic violence, as well as feeling stress frequently in the last 12 months. And what you see is for domestic violence, that's a robust effect. The covariates stay significant across all the models when other variables are added into the model. Same thing generally for feeling stress frequently in the last 12 months. With the exception of Model 3, it just is barely not significant. We did keep the demographics in the full model on the far right, Model 4. And we did this because we thought it was important context, and there are things that we wanted to look at, like race and ethnicity, as Susana mentioned. So witnessing domestic violence held statistical significance throughout the model. and significant. In model 4, we see some suppressor effects. So if you look at health status in model 4, we see that people that reported fair or poor health, there was significant effects there. So being in those health categories, you were less likely to meet the sleep recommendations. Being non-Hispanic Black, if you look down to the very bottom, is also associated with a decreased likelihood of meeting 7 or more hours of sleep. So we can go to the next slide here. So in summary, our findings document that there's a negative effect of exposure to domestic violence and sleep. And this aligns with the literature and the review study that Susana mentioned that was looking at 23 different studies that were looking at roughly the same relationship. But we did see that witnessing domestic violence remained significant through all the models, adding in all of the other covariates, even after controlling for experiences of stress in the past 12 months. One of the things that's, I think, important to point out about the full model is that having fair or poor health and being non-Hispanic Black are both associated with decreased likelihood of meeting 7 hours or more of sleep. And we think that this warrants further investigation. It really is just one additional health behavior that people of color, specifically non-Hispanic Blacks in Chicago, face in trying to remain healthy and engage in a behavior that's really important for health, as Susana mentioned, with obesity and diabetes and other chronic conditions like that. So these results, they contribute to an existing knowledge base looking at domestic violence and sleep. As stated previously, it's the previous studies that we've seen have not looked at race and ethnicity. So that's an important thing to consider. I think it's really important to consider how we best promote sleep amount, sleep duration, and healthy sleep among communities of color, specifically non-Hispanic Blacks. Some of the strengths of the study, one is that it represents diverse Chicago communities. You saw from the first table that there's kind of an overrepresentation of Hispanic and Latino communities, but certainly represents communities of color in substantial ways. The multi-stage sampling we see as a strength, as well as the in-person data collection. Many of the large epidemiological studies do it still over the phone, and so in-person probably offers some advantages in terms of completion, complete data sets, and even rapport with the interviewers. Examining the outcome based on race is what we think is really important about this study, and being able to know and document that non-Hispanic Blacks may need more support and more intervention in terms of assuring they can get adequate amounts of sleep. Some of the limitations to point out here, one is causality. It was a cross-sectional study, so we aren't able to say much about causality. We also don't really know, we haven't yet tried to see which way the variables go, so predictors of sleep duration, such as general health and stress, may explain not meeting those recommendations of 7 hours or more. The independent variable of ever witnessing domestic violence could also be interpreted very broadly by participants. There's really no time frame tied to that item. So it could be domestic violence experienced years ago or in childhood. So it's not the most precise variable for the purpose of our study. We also only looked at sleep duration, 7 hours or more as median sleep. We didn't attempt to look at sleep quality or anything like that. Because the study focused on these 9 Chicago communities, we can't necessarily generalize to other communities in Chicago or beyond Chicago. But we do think that these effects are interesting, and the suppressor effects are things that we're looking into to try to better understand why it seems like non-Hispanic Blacks are at greater risk of not getting sleep in the full model, but not in the simple models. So we will stop there, but we look forward to answering your questions. And we just also want to thank the DePaul Faculty Summer Research Grant for funding this research.
Fantastic. Thank you so much, Dr. Schober and Susana. That was really interesting to listen to. Again, everyone, I would encourage you, if you have questions at this moment, please go ahead and ask them in that chat. There's lots here, 2 really rich presentations to ask questions of. So feel free to drop them in and then we'll get to them after all of the presentations. So next up, we have our final oral presentation, which is Adapting Evidence-Based Programming for Community Implementation with Padraic Stanley, the program coordinator at Rush University Medical Center. And Padraic, I'll go ahead and let you take it away. You should be able to share your screen.
All right. Hello, everyone. Thanks so much for the opportunity. So let me go ahead and get my timer started because I tend to blab as well. So let's see. All right. So I'm here to talk to you about how we in our practice in the Department of Social Work and Community Health at Rush have just our experiences with adapting evidence-based programming for community implementation over the last couple of years, and just double checking that you all just see the slides, right? Okay, cool, because I have like a dual screen, and so sometimes when I share screens, things just go all over the place. So hopefully that's all right. So yeah, so today I'm going to kind of structure the talk in 4 different parts. Really quickly, just kind of going over like what is an evidence-based group program. So like, what are we talking about and what are some of the ones that we offer? And then I'll talk about how we adapted training for community leaders, and then talk about how we adapted programming specifically for the community, as well as give a little bit of an insight for accommodations that we made for virtual implementation around COVID, and then talk about some of the current initiatives that we have going on and how to get involved if you would like to. So for our first section, we're just talking about the evidence-based program. So what is an evidence-based program in general? So a program, it is typically an intervention that is over the course of multiple weeks, typically multiple sessions, that's proven by research, and it's proven by research in random control trials, and it's proven to be effective. But it's also mentioned to say that the evidence base is that it's proven to be effective for certain populations and for certain standards that are included in the initial research. So for example, some of the programs that I'm going to talk to you about are evidence-based programs for older adults, and they are evidence-based for people who are 45 years of age and older. However, that does not mean that people who do not fit in those stratifications that it's evidence-based for can't participate. So it just really means that that it's shown to be, if it's proven to be effective for a certain population. However, it doesn't mean that it's not effective for other populations to participate in that. And that also it's set for like certain standards. So for example, like we have a workshop called A Matter of Balance. That workshop is evidence-based. You would think that it would be, and it's a workshop around fall prevention. But you would think that the evidence base proves that it's effective in reducing falls. However, the evidence base for that program is that it's evidence-based for increasing confidence and decreasing fear of falling, which inevitably long-term reduces falls. However, it's evidence-based within the 8-week session to do those 2 things that it's evidence-based for. So it's kind of complicated, but mostly what's really important to know is that they're good data, a structured intervention, it's replicable and typically manualized. And depending on the model, facilitators have to adhere to certain standards. So whether it's like guidelines, qualifications to obtain or to maintain their certification, and those kind of standards and how the program is implemented and the materials that you need is typically managed by an agency, an organization, or a business that like kind of owns that evidence-based group model. And then there are other agencies who can take training, who can get access to that model so they can implement it throughout the community. So that's typically done through obtaining like a licensure from that organization. So licensures, a lot of them are free, while others have a cost. But mostly for any evidence-based intervention, you should be able to find local agencies who already have licenses and get involved with that. So I'm going to talk about that a little later in section 4 when I talk about like current initiatives and how to get involved. And then also know that training and fidelity monitoring is really standardized with these evidence-based programs. So essentially, if something is evidence-based, it's manualized, it has a way for you to like follow and how to implement it. And so essentially, if someone goes off and takes away parts from the program or adds parts to the program or completely changes it up, it's no longer an evidence-based program because it's not how it was studied. It's not how it was developed. So it's a little confusing, and we can always connect more about that to talk about it and to find out how you can get involved. But also know I'm a really communicative person. So if you have any questions, feel free to go ahead and ask them in the chat or whatever, or follow up with me afterwards if we don't have enough time. But some programs that we currently offer are chronic disease self-management, which is an overarching 6-week intervention for people living with chronic conditions. We have diabetes self-management, which is also over the course of 6 weeks, but specifically around diabetes and prediabetes, and for people who are caring directly for a loved one who has diabetes or prediabetes. We also have chronic pain self-management. So this is for folks who are living with chronic pain. Cancer, thriving and surviving, you can guess, is for folks who are active patients with cancer or who are in remission. Positive self-management is another 6-week group around HIV management. And a matter of balance, which I spoke to a little bit earlier, is a balance and fall prevention workshop that works on helping older adults overcome their fear of falling and helps them get back to higher social and physical activity levels over the course of 8 sessions. So I do want to talk a little bit about, because fidelity is such an important part of an evidence-based program, and a really kind of interesting and funny way that we use to talk about fidelity and how we adapt it for community implementation are these rubber duckies. So like your evidence-based program is your like typical, rubber duck. So it's like right there, he's got like the orange beak, he's got, they've got like yellow, they're not like customized. This is just the evidence-based intervention. But a rubber duck, but then you can see that rubber duckies come in like all sorts of like costumes and colors and sizes and attitudes. So you can really take a evidence-based intervention and dress it up for community implementation. But you have to like make sure that it's still a duck. Because when you take away huge chunks or you start to completely change like activities and change what the basic function of the workshop is, it becomes more of like a flamingo. Is it a duck still? Like all of these other ducks in like the previous slide, they're, you have like your peace duck, you have your like butterfly duck, you have your heart duck, but they're still ducks. So I'm fine with that. So if people want to like adapt their program, that's always kind of, as someone who monitors the fidelity of the programming for the people I train, I'm always asking like, is this something it's still a duck or is it a flamingo yet? So talking a little bit about that. So also just adapting the training for community leaders is something that's extensive, because oftentimes the training for these evidence-based models can be extensive and therefore can kind of alienate some folks who might want to facilitate groups but may not have the means to do so. So with that, I'll talk a little bit about how we were able to adapt some of these trainings for groups in the community. So first of all, let's talk about the training that we did. So we had the Promotores de Salud in the west side of Chicago. Sorry, I'm just gonna. Okay, all right, just was taking care of something really quick. So um, the Promotores de Salud, we were working with them in the west side, and we're trying to figure out how we could get them to implement, we could partner with them to implement some of these evidence-based interventions. And oh my gosh, I'm so sorry, my email is like blowing up and there's a notification that keeps coming on every single time. So I'm sorry that that sound is there. It's really annoying. But um, but essentially, we were working with them to try to figure out, how could we bring this evidence-based intervention out to the community by working with the promotoras. And so initially we were talking to them about the program, and a lot of them were saying, this is really great. This sounds like a really awesome intervention we can do. And also just by sitting down with promotoras and talking to them about like their professional development goals and what they wanted to offer for the community, we heard from them that oftentimes promotoras were um, oftentimes connecting people to services, and they were um, facilitating services and doing one-time talks, but that the idea of them being able to get the training to provide an intervention to them was just an amazing opportunity for them that they wanted to do. So we had a training in November of 2019 that some could come to, but then afterwards, after we trained those promotors, we trained about 5 of them. Uh, they just had immense capabilities for recruitment and retention, and their groups were phenomenal. So we had these promotores that were amazing, Laura and Adriana, and we said they wanted to do a group in January. And we said like, oh my gosh, there's no way that you're going to be able to like get people out in January. It's going to be cold, it's going to be snowy. And they were like, just trust us, we're good. And so like they went out and they like hit the streets and they talked to older adults. They went into laundromats and talked to older adults. They went to churches and talked to older adults. And they got this huge group to come in the middle of January, and they ended up having great completer numbers throughout. So it was just an awesome experience. And we said, we really have to like trust the community and really come together and really go off of that. So, but then when we went back to the promotoras and we said, we really want to like offer this, they said, the training is 4 full days. And a lot of them were straight up like, I have to pick up my kids at 3:30, so there's no way I can come to your training till 4:30. Sorry. And so we were able to get permission from the Self-Management Resource Center, who is the owner of the Chronic Disease Self-Management Workshop, which is what we were trying to train them in, and said, at first we said, we would like to do this training over the course of 10 half days. So instead of doing 5 full days for the promotores to get trained in the chronic disease model and the diabetes model, which is typically 5 full days, we said, can we do 10 half days? And then that way that would kind of work with their schedule, but they would have to kind of commit to like a longer time. And at first the Self-Management Resource Center said no. Like we asked them, they said no. Then we went back and said, after the promotores did their workshop and we said, this is amazing, like, that they had this amazing recruitment power and that they did this awesome group and we want to train more. They were like, okay, fine, we trust you, go ahead and do it. So we were able to get that special permission. And so we were able to get 17 promotores de salud trained over the course of 10 half days. And honestly, it was awesome. So unfortunately, we wrapped up the training the first week of March. So what happened right after that. But we'll talk a little bit about adapting for COVID so that we can talk a little bit about that. So again, just to kind of summarize what we did, to adapt the training, just listen to the population you want to engage. So talk to community members. So like what matters to them? What do they need? Can your programming help with that? And talk to community-based organizations. And it helps if that evidence-based programming aligns with initiatives that they already have taken on, and it aligns with something that they want to do. So if someone says like, oh, I really want to work more with older adults, we're trying to expand our older adult programming, then that's great. And then also just know, like, what are the necessary accommodations that would need to happen for them to be able to participate? And then make those adaptations, implement it, and evaluate. So time is flying, and so I want to talk really quickly about just how we're adapting our programming for community and COVID. So honestly, there's no substitution. The most effective way to adapt evidence-based programming for community implementation is to train and support folks with lived experiences from those communities. With that is the biggest way that we've kind of changed up our workshop model for evidence-based programming, is that over the years, we've trained our staff, we've trained our volunteers, we've trained our interns and students, and then they go out into the community and implement these workshops. And it was working fine, but there's just so much better retention, and it's so much more into health equity and community building, and it's just overall better now that we're working really with expanding the capacity of community-based organizations to implement these programs. So there's really no substitute for that, but doing it is really challenging. So essentially, how you can adapt the programs is leverage the expertise of community members and CBOs. So the folks who work in community-based organizations know their communities best. And as health institutions, we just have to reassess our role as more of a collaborator and colleague, and less as like an expert, and like really just leave the whole savior complex totally behind. It just is so detrimental to a relationship with a community-based organization to come in thinking you're the expert, and it's not going to work out that way. So just really leverage the expertise of community members and community-based organizations is necessary. Finding a location, so in like a post-COVID world and pre-COVID world, finding a location that's accessible and familiar to folks is so important, because you'd be surprised how many folks even don't want to venture out of their neighborhood. And then having community leaders vouch for your programs and encourage folks to attend, but that's only going to come if you've put in the work, if you've already built the relationships beforehand with those folks. And then within reason and within Fidelity, adapt the program. So folks are going to be able to know like how they can put their own culture, their own personality into the workshop and into the model. And that's going to come with like working with the folks who are the agency license holders, but then also with the folks who you've trained to facilitate, and supporting them in those initiatives, and then even consulting with the agencies as possible. An example that we do is that with our matter of balance workshop, we have adapted that to work with the Chicago Lighthouse. So we've trained staff from the Chicago Lighthouse, which is an organization that works with the vision impaired, and did a version of the matter of balance workshop that was using Braille with extremely large text, and then had a lot of adaptations for visual impairment. And then also just knowing that through like the 300 plus people that we see every year through these groups, there's a huge number of folks who have low literacy. So whether it's low literacy or low health literacy, we've had to really work to adapt the program and make sure that folks get the intervention and get a lot out of it. Now, since COVID-19 pandemic has hit, we've been having a lot of Zoom workshops. So Zoom workshops mean additional training and support for those facilitators, as well as providing a technical assistant for them that can help them do the technical aspects of the workshop. And then also we've been having a model where and here you can see our really awesome community facilitators from the Resurrection Project. There's Dania and Alicia facilitating their group. And there's me. I'm not like, I don't have my camera up because I'm the technical facilitator, a technical assistant for that. But we've also done it where we're now planning workshops where community leaders are facilitating, but then anyone who's kind of involved in our network of facilitators can join. And then for folks that are low tech, we have telephonic toolkit workshops that have self-guided materials, and they have a weekly check-in with a trained facilitator and 4 other participants through a conference call. So that's how we've kind of adapted for COVID. Again, just really quickly to talk about how you can get involved. For the Take Charge of Your Health workshop for chronic disease self-management, it is a 24-hour training that's given by 2 master trainers, and we offer those trainings 2 to 3 times a year. And then for the cancer model, chronic pain model, and HIV model, we offer an additional half-day training that can be completed after you've done that base model of the Take Charge of Your Health. And then a Matter of Balance training is only an 8-hour training that's given either over the course of 1 or 2 days. And all of these trainings are going to be virtual for the time being. So getting involved in those first kind of workshops, if you're in the city of Chicago, I am your contact. If you are in suburban Cook County, your contact is Joan Fox over at Age Options. And then if you're outside of Illinois, you would need to reach out to the Self-Management Resource Center, which is the agency holder for the organization. For Matter of Balance, if you're in the city of Chicago, I am your contact again. If you are hoping to implement programming throughout the north side of Chicago, that would be Michael Sweet at White Crane. And then again, if you're out of the city of Chicago or out of the state of Illinois, you would want to reach out to Maine Health, which is the agency that does that. So also, you can host a workshop at your organization at absolutely no cost to your organization or the participants. We provide all the supplies, assist you with recruitment, and then can also connect your participants back with Rush Social Work Services. And yeah, I'll be free for any questions during this question and answer time. And then also, here's my contact information. And then if you really want more contact information or don't want to write this down, you can scan this QR code here in the lower right. And that's like different ways that you can connect with me, whether phone number, email, Twitter, social media, all that stuff. So feel free to connect with me there. So sorry, I feel like I went a little bit over, but tried to do my best. But that is everything.
Great. No, a little bit over is just great, Patrick. Thank you so much. So that was fantastic. Thank you so much to all of our presenters. So now we have our question and answer time. I'd strongly encourage if you would like to take off your mute and we can make this more of a discussion, feel free to. It's a relatively small group, so I'm not too worried about it getting crazy. So if you'd like to do that, please feel free to. If you prefer to go ahead and put a question in the chat, then I'm happy to read that off for you. And while you're thinking about what your questions can be, I'd like to go ahead and start off, if it's okay, with a question for Dr. Schober and Susana. So I really enjoyed your presentation a lot, and I'm curious what you think next steps could be. There was lots of really interesting things you had there for limitations and thinking about how that could apply, especially with, COVID. Is this something where, what are your next steps for what you think with you'd want to do with this work, or do you think it's worthwhile to go ahead and share with, working with a domestic violence group, or what would be your ideal?
Yeah, well, our kind of motivation here was really just to ask the question and to try to figure out, is there a difference with racial and ethnic groups? So I think from an analytical standpoint, one of the next things to do is to look deeper into this, because from a statistical standpoint, if you just look at exposure to violence and sleep among African Americans, you don't see much of a difference. But when you look at all these different things together, that's when you see a difference. So trying to understand and tease apart what's happening, where that's coming from, I think is the first part. I think that there's also some implications for practice. I do not hear a whole lot about targeting communities of color for sleep-related issues. I think sleep is an area that's really just started to emerge as being connected to chronic disease and age-related disease. So I don't think that there's been much attention, with communities of color. So I think there's certainly a lot of public health outreach that has to happen to address some of these potential disparities. And the disparities we know exist, like heart disease, cancer, obesity, with communities of color compared to white communities. Susana, did you have anything to share? Any thoughts?
I mean, domestic violence now, it's like a really pressing issue because we've heard of instances of like, increased violences, and most specifically women and children are either a victim or who witness domestic violence. So I think like further, exploration of that topic would also be mandated to see if we could, incorporate something else like related to COVID-19. And also, like Dan said, we would play around with variables and see which variable is, affecting the relation between domestic violence and sleep, and just see how it differs based on race. So that's going to be our next step, just to play around with variables and see, which one's more significant.
Great, thank you so much. I appreciate it. And then again, anyone feel free to drop a question in the box. Padraic, I wanted to ask you something, if you don't mind. Not to harp on the COVID, but in one of the previous sessions, one of our presenters was talking about that it's adapting to COVID-19 restrictions has actually allowed for a lot of inventiveness and created practices that they intend to keep and hold on to. Do you see any of that in the work that you're doing?
Yes, absolutely. So I found that we've been engaging a lot of people who are caregivers. We've been engaging a lot of people who have transportation issues. It just has been really great to like engage people who wouldn't have been able to come to our programming if it was at Rush or at a community-based organization. And it's been nice to like really reach them, and we've been creative about how we're getting in touch with them. So we've been working with like homemaker services, home health companies, like friendly caller programs, like and just trying to like get out the word about social engagement, and how like those workshops are great for your health, but also great for meeting other people with common experiences. So that's been really great. And honestly, it was a kind of motivator for change for a lot of people in the aging network. I feel that like oftentimes we hear like it's a really awful stereotype that older adults are set in their ways, but that's absolutely not true that older adults are set in the ways, but the aging community, oftentimes those professionals are set in their ways. So when we've talked about virtual adaptation for some of these evidence-based groups years ago, they were like, no, absolutely not. That's not possible. And then COVID comes out and they're like, okay, I guess, like, so so that's been a really great way that now that we're talking about going forward about how, these virtual programs aren't going anywhere because we are engaging so many people who wouldn't be able to otherwise, especially since we're able to like adapt it for like conference calls too. So it's been nice.
Excellent. Thank you so much. I appreciate it. And we have some really great questions coming into the chat. So one from Magdelene. Dr. Schober, I did a research project on domestic violence, and there were findings of how it costs the US government $50 billion a year. So I wonder how much sleep problems and its other health implications contribute to this cost. Like you mentioned, there are some correlations to sleep and chronic illnesses.
Yeah, it's a great question, Magdelene. I think a lot of it would depend on how you measure that, because if sleep is related to obesity and it's related to cardiovascular disease and diabetes, those conditions alone, cost the country billions and billions in healthcare costs. So one of the challenges, I think, to trying to measure that would be, how do you allocate that, the cost of poor sleep to all those different conditions? It's a really interesting question, and I think that I've seen studies looking not so much at domestic violence, but just lost productivity due to people being so fatigued and so sleepy. So if you add in domestic violence to that, I think that it's probably an even bigger issue. And I think, like Susana mentioned in the background, during COVID-19, we're still trying to figure out how much of an increase has there been with domestic violence. if you look at different articles on calls to helplines and things, it's still so inconclusive. I mean, there's states that have seen big increases. Chicago has seen big increases. There's states that have seen decreases, and there's no real consensus on as to why it's so variable based on the city. So I think especially in COVID-19, the costs are probably going up, but it's a great question. I think that it would be really helpful if somebody had the answer to that, but I can only speculate today.
Great answer. Okay, fantastic. And one more for Dr. Schober and Susana from Rebekah. Are you looking at any interventions regarding sleep and domestic violence? Or are you solely focused on the exploratory research phase for now?
Yeah, Susana, what do you think?
It would be something that we could think about right now, but this is like an initial phase for our research. We're working on writing a paper, like academic paper for the same issue. So we'll go ahead with the study, like the paper for now, and see where it goes.
Yeah, it's a great question. And I think that, being at DePaul and being in Chicago, you have to ask that question, right? You can't just do the research. So I think, like Susana said, we're kind of focused right now on the research, but a lot of the service aspect would be kind of more through community-based service. So one example is I participate in the mayor's public safety research advisory council. And that is a group of local elected officials who are trying to figure out how do we address violence, gun violence specifically. But they're looking at research, and they're trying to implement things that have been found in research to inform the city of Chicago's efforts to address gun violence. And a big part of domestic violence is gun violence, right? And so I think that at this point in time, trying to take what we learned from this research and serve the city of Chicago, the mayor's office, nonprofits who might want to know more about this relationship, and really try to support the good work that other people are doing in the practice world.
Excellent. Okay, great. And I have a question too for Mariama and Rebekah and Magdelene. So certainly you're working with, of course, so you're working with one of the most underserved populations, Black homeless women. And it's such a charged political climate. I see the list of organizations that you're looking to reach out to and work with, and it's definitely here in Chicago, but I think I saw the University of Kansas even in there. So I'm curious how you see the political climate maybe working both for and against you in implementing some of this work and in finding grants, and like what challenges do you see or what advantages do you see?
Well, yeah, so our project was looking at, eventually the expansion of Medicaid, and I know there's like different views of what that could look like. And we've even had our own discussions of, things that are mostly government handled is problematic itself, but we're trying to see maybe if it could look different per county or start statewise or start city-wise. See if there can be some healthcare options just dedicated to that rather than going straight to something like national. Mm-hmm. But yeah, we would have to look more into that since this was pretty much a proposal.
Mm-hmm.
I forget who I was talking to. Maybe it was my partner, or maybe Mags and Mariama was us, but just about how basically our proposal has some socialist tendencies, right? Now we didn't say hey, this is a socialist, what, blah, blah, blah. We weren't thinking about the buzzwords around it. We were just thinking what would be most effective in helping Black women, especially if they're experiencing homelessness. And it started with Pap smears. How can we get better retention for breast cancer screenings, for Pap, for cervical cancer screenings, for these? That's where it started. And then the more we looked at that, we were what is what good is a screening if they don't have stable food and housing, right? And that just the idea of holistic care seems to be really, I feel like taking off based on, I don't know, the past year. Mariama, Mags, and I met at SWCH, did a research fellowship program over the summer, and that's how we met. And we were a part of a research group, and this is just where we ended up. And what was I gonna say? I feel like if we, I don't know, I'm not afraid to talk about controversial issues, but if we really focus on the population and the fact that this is just more effective and really focus on the facts of it rather than getting lost in a political narrative, I'm hoping that would be effective. Those are just my thoughts.
Right, and to add on to that too, like that's why we started with just looking at the Chicago population. We found that there was just so many non-for-profit organizations, and like, you know, I feel like so many people who need these like opportunities just don't know what's really out there to help them. And so we're thinking maybe something more universal would be helpful, especially like I've heard like there's some hospitals shutting down in Chicago, and that like screws up with like the proximity with certain populations. And so yeah, we wanted to look at what would it look like if we can make this something universal.
Fantastic. Yeah, I'm wishing you all the best. It was a fantastic presentation. So we have some questions for Padraic in the chat. So from Mariama, earlier in the discussion, you mentioned that you have had more people participate in community leaders programs virtually. Would you and the organization still have both virtual and in-person workshops once things clear up with COVID?
Yes. Unequivocally, yes. Yeah, we like definitely want to continue both like in person and virtual because there's pros and cons to both. So just to make sure that like everyone's involved, is we're doing virtual, phone call, and in person as soon as we're allowed to do in person. So
great, thank you. And then also for Padraic from Susana, you mentioned there are self-management programs for, oh, the chat's moving, sorry. You mentioned there are self-management programs for chronic diseases such as diabetes and others. Could you elaborate more on the self-management measures and the techniques being used in these programs?
Sure. So also, yeah, and as like virtual implementation happens and in-person implementation, we're supporting all of our community partners and as they're working into those transitions as well. But yeah, in general, the chronic disease self-management, so it's over like 6 weeks, and it uses a lot of like psychoeducation, but then also like cognitive restructuring and confidence building. But then it also like works on like emotional management and understanding like cycles of chronic conditions and how like stress can lead to like poor diet, and poor diet can lead to like fatigue. It's like, so we talk a lot about like how we break up that circle, and really try to help people make small steps in breaking up that cycle of their chronic conditions. And what's cool about that is that like it's done in like a very non-judgmental way. So we always make sure that at least one of the facilitators has a chronic condition themselves, or like identifies as well, so that they can also provide like good modeling for that. Yeah, and then also like, so at the end of each session, we collaboratively as a group make very concrete goals for the next week. So they're basically like achievable like action plans that we do over the course of the week. And then during the week, they receive a phone call from one of their group members, where they kind of check in on how they're doing with their weekly goal. And then at the beginning of each session, we spend time all reporting back as a group on like how we did with our goals for the week, and then doing like encouragement and support and also problem solving for people if they had difficulty with their goals. So even though it's like not directly related to like what people consider like chronic condition management, just like that setting weekly goals and doing problem solving when we're like presented with like challenges and getting that goal is around like 35% of our group. Every session is just like setting goals and checking in about the goals. So it's like so it's kind of like a blended like health ed, psycho ed, and support group kind of all together. So
Thank you so much for the explanation. I really think that it's really thoughtful for you guys to incorporate like someone with the chronic illness to be a facilitator so that people like community members can relate better to them. So I think that's a really great intervention being in use.
And Padraic, I have another one for you from Rebekah. Have you experienced any difficulties with regards to approaching community collaboration in terms of the savior complex you mentioned? I'm curious to the perspective of someone working from a healthcare professional setting and barriers you may have faced with your progressive approach.
Oh yeah, so I typically like avoid savior complex stuff when it's like community organizations and folks from the community getting trained, because it typically is not a problem. But a lot of time we have like nursing students, social work students, like a lot of like, or even like students from all over like the medical field that are like, I want to go in and like provide a chronic disease. I want to go in and educate the community. I'm like, ugh. So basically that's before anyone goes through the training, I kind of have like a sit down discussion with them about like what their motivations are and kind of talk to them through that. And talk about like kind of that, how that may or may not like align with like the goals of the program and kind of how like the I guess like the spirit of the program and how we're trying to implement it. And then that person will kind of like always, like I would never, like all the groups are also co-facilitated by 2 people. And so I'm also very mindful about like who I'm pairing together. So like if I have a person who's like a student who's not from that community, I will literally 100% of the time put them with someone who's like not a student and is from that community and has that lived experience so that they can co-facilitate together. Rather than like some agencies who have done it in kind of less intentional ways. Sometimes they're just like training people and then dumping them into a community and being like, like, thank you for being available and please facilitate this group.
Awesome. Thank you, Padraic. That's a great technique. I'm going to skip around a little bit on questions, and I'm going to go for Magdelene, Rebekah, and Mariama. It looks like, this is from Dr. Schober. It looks like you have a great group of stakeholders. Can you share how you brought them all together, got them on the same page, and are working together effectively? What have been the biggest challenges, and what have you learned about working with such a broad coalition of partners to address these health issues?
Thanks for the question, Dr. Schober. So full transparency. So we haven't I have talked with several people for the stakeholders that were put into the slide in terms of potential collaboration partners, but it is more in the like hypothetical stage than we're actually implementing this right now, right? So I'm about to graduate with my bachelor's, actually. I think Mariama is in a nursing program and Magdelene is in a master's program currently. So we're all kind of at the beginning of our research and research careers. And I know when I did speak with some of the stakeholders that you mentioned, for example, I think Emily saw that the University of Kansas was on there for the sexual empowerment and health. They had a really wonderful model where they particularly looked at, sorry, I'm just trying to remember. They worked with a lot of people that experienced homelessness. I don't know if they looked at cervical cancer specifically, but they did look at health issues. And I think maybe HPV was more centered towards sexually transmitted diseases. And sorry, my brain, it's rough. COVID times.
It's a Friday
oh
afternoon, gosh. Long election week. I totally feel the same way.
No, it's been real. But just talking to them, they were really open to just helping us understand like how do we approach this, and they approached it with similar methods that I think, is it Padraic? I'm sorry if I'm butchering that.
That's okay.
How do you say it?
It's Patrick with a D, so it's just Padraic. Yeah.
Oh, Patrick. Okay. What was I gonna say? So they They had a very similar approach that was they would ask them about their lived experience, and this idea of really valuing qualitative research more. Not to say quantitative isn't powerful. I think predictions and understanding significance is really instrumental. But I think I think mixed methods is a really good way to get more community-based approaches funded. That's kind of where I'm seeing it. That's where I'm kind of hoping my career goes, and using mixed methods so we can work with community partners and who's being affected, understand the problem, ask them, have them in the picture like Patrick is talking about and currently implementing. And I'd love to collaborate further in the future, Patrick, because the training that you're talking about, I think, is the future. Like I hope that is implemented more. I'm not sure how common that is. So I'd be curious to your feedback, like, and like, is this really new an initiative? Like, how long have you been using that model? But anyways, I'm rambling a bit, but I'll pause there.
Well, it sounds like you've identified the right people and made a good connection and found the right issues. So I think that is a big part of the groundwork. So congratulations.
Thank you.
Yeah,
Great.
that's awesome.
Fantastic. We have another chat here. So thank you everyone for the great presentations. These are all very interesting projects. For Patrick, I think that you make an excellent point that it's important for large healthcare settings not to go into collaboration programs with community-based organizations, thinking they are the experts. It is important to be mindful. They know the community better and rely on their expertise to bring community members together. So maybe not so much a question, but definitely a strong comment there. Great. And then one more question for Patrick, and I think that's going to be probably it for us for today. But Patrick, from Dr. Schober, I think implementation fidelity is incredibly important, especially in clinical settings like Rush. How have you used technology to help measure and monitor the fidelity of implementation?
So it's actually been a lot less disruptive for like those. So like thankfully, like once you're like a trainer of like the programs, you get training in like how to do fidelity monitoring, which typically with groups, there's no substitute for like just sitting in on a group and like with a checklist and making sure that certain things are being followed. And then it also is like a great opportunity just to work with your group leaders to like talk with them, even like, because I'm a social worker and like groups are like my thing. And so like when I have like community health workers or community members or nurses or occupational therapists that aren't necessarily used to running groups, it's always an awesome opportunity for me to double check their fidelity, but then also just like gives them some tips and tricks for like managing groups. And it's, but yeah, it's actually with the virtual implementation, it's actually been so much better because I can just so much more discreetly pop into like a group and like just stay with like my thing. So I'm not interrupting the group process at all. Whereas a lot of times like for these community-based organizations, like for me going in and like observing a whole session was like, was kind of disruptive, but I would just kind of like have my facilitators, like when we were in person, have my facilitators like a week ahead of time, like tell them like, hey, like our program coordinator's coming in, he's going to be observing us just to like make sure that like we're doing a good job and like to help us out. And then they would like, as long as they knew ahead of time it was good, then I would like literally just sit into a corner, like not say anything for the whole time, like, and then when they would like go on break, I would like chat with the facilitators a little bit, like let them know, I would follow up and then dip out, like just to try to monitor fidelity but be as least disruptive as possible is so important.
Great. It sounds like technology allows you to be a little less obtrusive in some ways.
Yeah, absolutely. Because yeah, I can just come in, like no camera on, no mute. I can just like be muted, and then I can like private chat like my facilitators and be like, "That was great, cool. Like, look out for an email from me with more comments. Like, keep doing a good job." Like, and then I'm satisfying my fidelity requirements and supporting and making sure that the facilitators are good. But also like with my facilitators, it takes a lot of time. Like, and doing things intentionally and doing things right just honestly takes so much time. And So when like we have like an active group, I'm like literally meeting with my facilitators every week just to like check in and make sure they're supported and like consult with them. And even if it's just like a 5-minute phone call, it gives them the opportunity, and sometimes it's way longer. So
Thank you.
Well, thank you all so much. We're nearing the end of our time here. I just wanted to say this has been really fascinating. I really appreciate you all taking time to join us today and your engagement. And to our presenters, this has been fantastic. So thank you to Magdelene, Rebekah, Mariama, Dan, Susana, Padraic. Really awesome work you're doing, and it was wonderful to have you share it with us and let us know more about it. Thank you so much. We are nearing the end of our day for our conference day as well, but please keep in mind, we do still have the afternoon keynote presentation, and it should be a really great one. So I would encourage you to head over and join us for that. I'm going to go ahead and put the link to it here in the chat to make life easy for you. So you can go ahead and follow that. It'll start here in about 10 minutes, so you have enough time to stretch, grab some water, and then join us over there. Again, thank you all so much. If I can answer any questions for you, please let me know, but it's been a pleasure. Have a great afternoon.
Thank you for facilitating, Emily.
Oh, absolutely. Thank you so much, Dan.
Thank you.
Thank you.
Thank you.
Bye-bye.